everyone. I'm Lundi-Anne, and I will be presenting a case study based on one of our humanitarian response projects in conflict settings in southwest region of Cameroon. This was actually a project implemented within a framework of actually responding to the humanitarian needs of displaced communities in very hard to reach areas. And the context in which this project was implemented is actually that which has suffered from protracted armed conflict since 2017, resulting to the displacement of close to 1 million people internally within the country and corresponding destruction of health facilities in those affected regions. And due to the conflict dynamics, accessibility to the communities that were targeted was largely by sea. We had very limited or no access to the communities by road due to incidents relating to gunshots, kidnapping, and the other. So the model that we used had a multi-sectoral approach that did not just address health issues, but also did try to address other sectoral issues related to water hygiene, sanitation, NFI keys, and it made use of community health workers and protection volunteers that did work hand in hand with referral hospitals and also with the mobile health team that was centered or that was stationed in one of the center community in the district of interest. Training of these community health workers lasted for about 5 days and included models that did cut across nutrition, health, distribution of NFIs, and also child protection component. And within the health models was integrated aspects on early identification and notification of diseases under surveillance by the Ministry of Health within the integrated community case management package. And like earlier on mentioned, we had a mobile health team stationed in one of the communities that was responsible to ensure timely verification of suspected cases when they were notified by the community health workers, and also collection of the samples and transporting the samples to the referral hospitals. And we had to do a lot of community engagement to get acceptance from community, because we were operating in a context where there was a lot of suspicion between non-state armed groups and those and humanitarian workers bringing humanitarian operations in the field. So to gain acceptability both from the community side and also with the government side, with the MOH, we did actually ensure timely feedback. And this allowed us to have the tools which we needed to collect the samples. And when the mobile health teams were notified, supervision of the community health workers and child protection volunteers was ensured by the mobile health team, and this was done largely on a monthly basis, unless we had suspected outbreaks or cases being notified by the community health workers. Reporting was largely paper-based, except for when cases were notified for suspected cases of outbreak like measles, monkeypox, cases which we actually did confirm in early 2020. The community health workers did not just report cases of disease outbreaks, suspected cases, but also were in charge of reporting security incidents, because this did affect how our programming was tailored to ensure that we're actually reaching out and meeting the health needs of the communities. Data was collected largely by community health workers by home visits, like home to home, on a home to home base, and actually submitted largely on a monthly basis, except for cases that were notified for suspected outbreaks. At the end, since this was a humanitarian response project, it's usually short-lived, 6 months to 1 year program. And at the end of the day, before leaving the community, we had community conversations with community leaders on how these interventions could be sustained beyond the project's lifespan. One of the things we learned during our program implementation was the timely involvement of communities even at the level of selecting the community health workers who were, for the greater part of the communities, displaced as well within those communities. And this allowed us for timely intervention, and also it did allow us to provide timely feedback to the district health service, who did provide us with the tools like sample collection vials, and in the case of the measles outbreak, they did provide us with the vaccine that was needed, the vaccines that we used to conduct the ring vaccination to contain the outbreak. Much more detail on our program is found in the publication, which you see. I think we're going to also share it in the app so that anybody who wants to read more about it could do that. So, yeah, I wish to thank all the team with whom we did carry out this intervention, and also thank the Ending Pandemics team for inviting us to share our experience. Thank you.